Once again, I thank the organizers for this wonderful workshop and conference. And I see a lot of people still here at this late hour. Actually, this was a slightly long presentation, but I'll cut it short in view of the fact that it's getting late and everybody is wanting to go. So let me start. So lumbar interbody fusion has become a standard of care now. Why I say standard of care now is that when we started doing surgery about 25-30 years ago, we were all doing a simple laminectomies or stiffy plating with, bone on the lateral aspect of the plate, and then we started doing PLIFs, PLIFs. We started putting iliac crest grafts, and then we gradually have come to, doing T-lifts and minimal access, and the safety and the outcomes of surgery have improved significantly and qualitatively. So options for lumbar interbody fusion are still a lot other than T-lif. We have O-lif, we have K-lif or A-lif, and nowadays we have a minimal access OOLIF. That's something new that's coming up. So these operations are performed typically minimal access nowadays, and it is becoming very easy to learn for people. All you got to do is learn the steps. So I will say how to go about doing this again. We had a demonstration yesterday. So you basically do for degenerative disc disease at one or more levels, for failed back syndrome, for spondylolisthesis. And it begins with getting x-rays, dynamic x-rays, standing, AP and lateral. And of course you get a MRI, lumbar spine, whole spine screening. And nowadays, last few years, we're getting a whole spine x-ray. Look for spine sagittal alignment. Yesterday we had a small class about how to approach sagittal balance in a very simple fashion. So let's start this case. 56-year-old lady with low back ache, progressively increasing with radiation to the left lower limb, numbness in the left lower limb, left ankle dorsiflexor and EHL weakness. She had a hyposthesia of L4-5. And this shows an MRI which is a grade 2 listhesis, with of course the foramen being completely squashed. Flexion, extension, neutral x-rays confirm the same. Whole spine, hip joints. You can measure the joints, Yesterday, I think, I'll remind yesterday what I showed. That, is it coming? Yeah, I can see? Okay. It's true. You have a brighter light? So just to remind youngsters, yesterday I said pelvic incidence is between 45 to 50 or 50 plus or minus 5. Lumbar lordosis should be plus minus PI, isn't it? So in this particular patient, the PI is 47, the LL is 55. It's okay. No. So the balance is pretty good, but the patient has pain. I don't use any frame, just a natural frame. I don't use the frame on top. I normally use a pro-neutral position. And yesterday we showed the skin incision and how we mark it. You saw the same thing yesterday. We use a matrix retractor. You can use any retractor. We use this retractor simply because it has a capability to expand and have angulation. Very convenient to use. And I use this special disc removal discectomy instruments. The most important thing is to understand what a discectomy means. You just don't be in a hurry to do a little bit of discectomy, push in the bone, and a little bit of bone and the graft and come out. Make sure to do a good discectomy. I'll skip the video for lack of time. And you use any kind of graft like PEEK or titanium made cages. You can use that. You can use a banana, bullet, whatever cage you want to use. But make sure that you place it in a place that you want to do it. Do you have the pointer? Otherwise, is it seen? Try to place it in the anterior part. That's the important thing. And try to place it in the center. Because these are bullet and banana cages, I think placing it into one side will give not a great optimal weight balance. And if you keep it right in the front and you gently compress posteriorly, you get a decent lumbar lordosis. Now, many times you are asked, what happens if there is a single level and you don't bother about sagittal balance? It will come back to bite you after a few years. And I have started, some of them I have revised myself. And you can do the pedicle screw fixation, open or minimal access. I think all of you are now very familiar. But what I want to show you is a technique which is called a rocking technique. I don't know how many of you use it. And this is a very interesting technique which I've described, and it is in the literature. You can put pedicle screws and you can rock like this. You see? And you can reduce the listhesis. This technique will not necessarily make the screw loose. Please understand. I'll play it again. Thank you. Oops. You can use it like this and the screw won't become loose. But make sure, the screw are very placed medially. And you can see the X-ray again. And I can use this for grade 1, 2, 3 listhesis, grade 4 listhesis, and it helps in reducing the listhesis. The other technique that I use is, I don't know if you use this, once you clear the disc space, and if it's still rigid, you use this these trials, the ones which are here, you use the trial to go anterior and break the ALL. You can go anterior, push it all the way here, not completely, about half of it should go. At 2-3 places, it stretches and relaxes the ALL, and then you can easily reduce the listhesis. So you can use several tricks to reduce the listhesis, okay? And you get a very good result. So you can do it multiple levels. You can have a degen with a listhesis and degenerative disc. You can do that. Multi-level. Yesterday I showed some scoliosis, degenerative scoliosis, like this. It can also be done. Minimal access. One of the things that we do is, if you feel that you can only do with this, you can do 1 level, 2 level, 3 level. But you want to do additional level, you can use a matrix tube instead of the quadrant, a small hole. You can add another level if you want. This adds another half an hour extra, but you can get a cage here if you want. And you can get a correction. And as I told you yesterday, correction of lumbar lordosis, to what extent you want is still a debatable issue. But if you want to get a good lordosis, try to see what is the optimal level, and if you can reach 60-65% of it, it should be good. You can use additional gadgets, navigation, 2D, you can use a robot. Of course, you need AIIMS. And make sure that you avoid having pedicle breach and screw malposition. All of us have done it. Now, one of the things about screw position in minimal access is that if it is inside the canal, and if the patient has a symptom, don't hesitate to go back immediately to replace it. Get post-op x-rays if you want, or scans to confirm it. Ideally, if you are using any navigation machine to put the screws, intraoperatively get a check x-ray, C-arm, to make sure your screws are in position. It saves you a ton of trouble post-operatively. So there is a lot of classification of the screw positions, etc., etc. And we discussed osteoporosis. Osteoporosis means that you should be very cautious in using screws. Use larger size screws. Don't tap too much. Make sure the patient has had teriparatide therapy if you can wait for the patient to have a better bone quality. And you can use bone augmented fenestrated pedicle screw fixation. Now, what happens is, when you're trying to put a screw in a minimal access in an osteoporotic patient and the screw becomes loose, there are many ways of doing it. You can use a bigger size screw, or you can use a fenestrated screw, or what we do is we inject slightly liquidy bone cement into a loose screw hole, wait for just a little bit and put the screw in, and it holds nicely. So I have got a lot of patients, but for lack of time, I think I'll close now. Thank you very much for your attention.